Hello, everyone. Good morning. It's time to start this session. Thank you and welcome for joining us. This is a channel. Hello, everyone. Good morning. Thank you and welcome for joining us. This is a channel. 괜찮나요? 됐나요? Okay. Yes, this is channel 3, Symposium 17. The session of bariatric, current status of bariatric and metabolic surgery. I'm Joo-Ho from Eulji University, and we'll chair this session with Professor Sungsoo from Korea University. Professor Park, Hyun.
Thank you so much for introduction to
our audience. Would you please greet to our audience?
Hi, attendants. Good morning and good evening, Dr. Pryor. I'm Sungsoo Park from Korea University. I will produce the discussion after the 4 talks of the speakers. Thank you.
Okay, thank you. We have 4 presentations in this session. Before starting the lectures, I'd like to introduce our speakers and their titles briefly. The first speaker is Kyung-Won from Kosin University, Busan, Korea, and he will give a lecture titled Sleep Gastrectomy, Why Is It So Popular? Second speaker is Sang-Hyun Kim from Soonchunhyang University, South Korea. We will talk about Roux-En gastric bypass. Is it still standard? Third topic is gastric band. Should we abandon gastric band? Which will be presented by Professor Song-Min Kim from Gachon University, Incheon, Korea. And the last speaker is Professor Aurora Pryor from Stony Brook University, New York, USA. Her title is Reduce Bariatric Surgery When and How. We already got their pre-recorded presentation files, and we'll stream all of the files without intermission. So please enjoy their lectures, and after all lectures, we'll have a time for Q&A with our speakers. Please feel free to ask our speakers.
Thank you, Chairman.
Question buttons at the right of the screen or via the chat window. Professor Park will moderate the Q&A time. Thank you, everyone. Let's start.
Thank you, Chairman. Good morning, ladies and gentlemen. I am Dr. Seo from Kosin University, Busan, Korea. I'm very happy to present today about my topic, sleep gastrectomy. Why is it so popular? In a morbidly obese patient, bariatric surgery can reduce their weight very well, and it's effective in maintaining weight loss in the long term. Red dotted box indicate frequently performed 2 procedures of bariatric surgery in the world. Roux-En gastric bypass accounts for a large majority of the bariatric surgical procedure performed. It is estimated that 200,000 such operations were performed in the United States in 2008. But sleeve gastrectomy emerged a new procedure as a primary one recently. Bariatric surgery is the most effective treatment for patients with morbid obesity. Until recently, Roux-En gastric bypass was regarded as the standard bariatric procedure. However, sleeve gastrectomy is being performed with increasing frequency despite of lack of the evidence regarding its long-term efficacy. The sleeve gastrectomy procedure is technically easier, faster to perform, and potentially safer compared with Roux-En gastric bypass. Laparoscopic sleeve gastrectomy is one of the newest types of weight loss surgery to treat severe obesity. Historically, it was used as the first step in a two-staged obesity treatment. It was found that some patients lost enough weight with a sleeve gastrectomy alone, and that the second stage of operation was not required. The emergence of gastric sleeve as a primary procedure has resulted in a shift in the world of bariatric surgery. Gastric sleeve works through two highly efficient weight loss mechanisms. First, it makes the stomach smaller so that patient consumes a lesser amount of food. Second, it also removes the fundus part of the stomach, and it affects the action of the hunger-stimulating hormone called ghrelin. With the removal of ghrelin's action, a person feels less hungry, which in turn leads to reduced calorie intake and thus promotes weight loss. Is sleeve gastrectomy the most popular procedure in the world today? The answer is yes. According to IPSO Registry Report 2013, Roux-En gastric bypass is the most commonly performed procedure in the world. However, the case number of sleeve gastrectomy increased 5 times in 2011 compared to 2008. In Asia Pacific area, sleeve gastrectomy has already become the most common surgical procedure in 2011. In IPSO Registry Report 2018, sleeve gastrectomy accounts for 56% of all types of surgery. The total number of sleeve gastrectomy is 10,000 more compared to Roux-En gastric bypass. In the same report, sleeve gastrectomy is the main procedure on the most continents. In Western Europe and North and South America, Roux-En gastric bypass is a bit more performed, but the difference is not so big. Now, we start this topic in a concept of two major components. One is effectiveness comparing bypass. Second is the safety after bariatric surgery. We are looking for retrospective data concerning estimated weight loss effect. This report is the multi-center clinical cohort study comparing Roux-En gastric bypass and non-surgical matches in the left diagram. And this study also showed 4-year weight change who underwent Roux-En gastric bypass, adjustable gastric banding, or sleeve gastrectomy. This study described Roux-En gastric bypass is more effective at promoting long-term weight loss among obese patients. In this meta-analysis, including 80 studies used bypass, banding, or sleeve gastrectomy, the studies are prospective, retrospective, or randomized clinical trial over 5 years follow-up included. In this study, the conclusion is that Roux-En gastric bypass is an effective procedure in morbidly obese patients that leads to sustainable weight loss over the long and very long-term period in compared with gastric banding and sleeve gastrectomy. This randomized control trial conducted in France, IRCAD, concluded that Roux-En gastric bypass and sleeve gastrectomy resulted in equivalent, long-standing QA improvement. Roux-En gastric bypass resulted in more stable weight loss but was associated with higher readmission rate. By the results from meta-analysis of randomized control trial comparing sleeve and bypass showed that significantly greater in percent excess weight loss after 5 years of Roux-En gastric bypass treatment. However, it seems to have a higher incidence of total complication. There were two randomized control trials comparing laparoscopic sleeve gastrectomy and laparoscopic Roux-En gastric bypass at 5 years follow-up. Two articles were published in JAMA 2018. One is sleeve pass and the other is SM BOSS trial. Among patients with morbid obesity, use of laparoscopic sleeve gastrectomy compared with laparoscopic Roux-En gastric bypass did not meet the criteria for equivalence in terms of percentage excess weight loss at 5 years follow-up. Although gastric bypass compared with sleeve gastrectomy was associated with greater percentage excess weight loss at 5 years, but there are no conclusions about whether gastric bypass is clinically superior to sleeve gastrectomy. However, both procedures resulted in sustained weight loss with a mean excess weight loss of 49% in the sleeve gastrectomy and 57% in the gastric bypass group. There were no statistically significant differences between sleeve gastrectomy and gastric bypass for the second study outcomes of type 2 diabetes remission, dyslipidemia resolution, and QoL improvement. The compared with sleeve gastrectomy, gastric bypass resulted in better resolution of hypertension. Sleeve pass trial showed same result of weight loss between two groups. In the individual diagram, in the left diagram. In the right diagram, longer term follow-up may be helpful to determine if these differences result from loss of effect of sleeve gastrectomy or from greater weight loss after gastric bypass. SM BOSS trial also showed same result as sleeve pass trial. Among patients with morbid obesity, there was no significant difference in excess BMI loss between sleeve gastrectomy and bypass surgery at 5 years of follow-up after surgery. By fourth IFSO Global Registry Report 2018, average percentage of weight loss after surgery was reported similar between bypass and sleeve gastrectomy. In the same report, we can see the similar remission rate of obesity-related disease, for example, type 2 diabetes, hypertension, sleep apnea, etc. It is the same as prior to surgery and 12 months after surgery. There are some other options after weight loss failure or weight regain after sleeve gastrectomy. In the case of revision in patients who have failed to lose weight after sleeve, we can think of adding band or re-sleeve. Adding duodenal switch as a method of revisional surgery after sleeve is considered quite reasonable, considering the origin of the original development of this surgery. According to a report of Daffrey of Belgium, when comparing re-sleeve and addition of duodenal switch both are feasible, but a fistula can develop after re-sleeve, which is quite difficult to treat. In the case of duodenal switch, complications that cannot be ignored can occur. The weight loss effect was reported to be better with duodenal switch than re-sleeve. So, to avoid weight loss failure when sleeve gastrectomy, we should consider a few things when choosing a patient. It is better to avoid super obesity. Using a tight lot of about 32 French, you will need to ovulate so that there is not much antrum left and that there is no fundus left at the last stapling. Like all restrictive procedure, this should also be followed up more thoroughly to properly control the weight regain in the outpatient clinic. Marginal ulcer at gastrojejunostomy site is the unique complication after Roux-En gastric bypass. Its prevalence varied by reports, maximum 25%. It is very complicated to treat because symptoms are bleeding, perforation requiring emergency operation or endoscopic procedure. If the surgeon does not choose bypass surgery, marginal ulcer complication would not happen. Iron deficiency anemia after bariatric surgery is more frequently observed in malabsorptive procedure than restrictive procedure. According to ASMBS nutritional guideline in 2016, the prevalence of iron deficiency is reported under 18% in sleeve and 20 to 55% in bypass surgery. The last issue that we prefer gastric sleeve is the gastric cancer arising at remnant stomach after Roux-En gastric bypass. Until now, in the literature, 17 patients remnant gastric cancer after bypass surgery were reported. Although remnant stomach cancer after Roux-En gastric bypass very rarely occurred, but because it is impossible endoscopic evaluation at remnant stomach and diagnostic workup such as CT is troublesome. It would be found when cancer is more advanced staging and may be inoperable. Moreover, Korea and Japan is the pandemic area of gastric cancer, so most of Korean surgeons worried about this issue. It is one of the reasons why we prefer sleeve gastrectomy as a primary choice. In conclusion, the result of a comparative study with gastric bypass surgery, which has been the standard for severe obesity surgery for a long time, but sleeve gastrectomy has an advantage over bypass. Weight loss results not fall behind. The diabetes improvement results are also similar to gastric bypass surgery. There are no serious complications such as dumping, marginal ulcer associated with gastric bypass surgery. And regular checkup using an endoscope are possible. For this reason, sleeve gastrectomy has now become the world's most popular bariatric surgery procedure. Thank you for listening.
Good morning, ladies and gentlemen. I'm Sang-Hyun Kim in Soonchunhyang University Hospital. Today, I will present on how Roux-En gastric bypass is still the standard. I have no conflict of interest in my presentation. Picture taking is allowed. According to the Cambridge Dictionary, standard means a pattern or model that is generally accepted as a noun and usually rather than special, especially when thought of as being correct or acceptable as adjective. When I erased everything except the adjective, only the following words remained. So, if Roux-En is still standard, it must be an evidence-based, effective, and safe procedure with easy access. First, let's verify whether Roux-En has effectiveness based on evidence. To determine the effectiveness, I will check weight loss, type 2 DM remission, and other comorbidities. I will cite data from the last 5 years, mainly for meta-analysis, randomized controlled trials, corresponding to level of evidence 1 or 2. The table at the top is a table that evaluates the superiority between the Roux-En gastric bypass and other bariatric procedures. For example, if the weight loss in Roux-En gastric bypass group was significantly better than that in sleeve gastrectomy group at 3-year follow-up period, I will write number 1 in the red space equal to the Roux-En color out of the 3 intersections where the mid row and the sleeve gastrectomy column meet. Let's start with weight loss. In Assembles trial published in JAMA, there was no difference in percent excess BMI loss between the two groups, but Roux-En gastric bypass was superior with percent total weight loss than sleeve group. In sleeve PASS trial, although gastric bypass compared with sleeve gastrectomy, it was associated with greater percent excess weight loss at 5 years. This difference was not significant, based on the pre-specified equivalence margins. This study compared mid-term and long-term weight loss outcomes and comorbidity resolution of Roux-En and sleeve gastrectomy through a meta-analysis of comparative studies. Roux-En showed better weight loss in the long term and similar result in the mid-term. This meta-analysis shows long-term outcomes over 10 years. BPDDS produced the greatest weight loss with a pooled effect size of 71% excess weight loss, followed by Roux-En with 60%. Data were insufficient for a meta-analysis of the sleeve gastrectomy, but it showed mean of 57%. Next, I will check type 2 DM. In Assembles trial, complete remission was seen in 68% in Roux-En gastric bypass group and 61% in the sleeve group. There was no difference. Also, in sleeve PASS trial, there was no significant difference between the two groups. And in mid-term and long-term meta-analysis, there was no significant difference between the two procedures for diabetes resolution. I tried to find mid or long-term RCTs or meta-analysis between Roux-En and other procedures such as MGB, SADIS or DJB with sleeve, but couldn't find them. This study was a comparative study between MGB and Roux-En during a 3-year follow-up period, and showed that there were no significant differences in percent total weight loss and diabetes remission rate. This study was a comparative study of 3 groups, Roux-En, BPDDS and SADIS and 3-year follow-up. Percent total weight loss and diabetes remission was higher in BPDDS and SADIS group than Roux-En group. To date, there was no mid-term or long-term comparative study between Roux-En and DJB with sleep. The study was compared 3 types of bypass surgeries, Roux-En, MGB, and DJB with sleep at 1-year follow-up, and DJB with sleep procedure was significantly higher in weight loss. Another study was a randomized trial at 1-year follow-up. It showed that DJB with sleep has similar effect to Roux-En in weight reduction and resolution of comorbidities. Then, let's see hypertension. In SMBOS trial, remission rate was 70% in Roux-En group and 62% in sleep group. There was no difference. But in sleep test trial, remission rate was 51% after Roux-En, significantly better than 29% of sleep group. In this meta-analysis, there was no significant difference both mid-term and long-term resolution of hypertension. In resolution of dyslipidemia, there was no difference between 2 procedures in SMBOS trial. In sleep test trial, and also in this meta-analysis. In resolution of gastroesophageal reflux disease, as we already predicted, Roux-En was significantly higher than sleep group. How is the safety of Roux-En gastric bypass? Let's check the complication, mortality, and reoperation rate. In SMBOS trial, early complication of sleep group was 0.9% and Roux-En group was 4.5% with no difference. In sleep test trial, there was more early minor complications in Roux-En gastric bypass than sleep gastrectomy. But there were similar early major complications in both groups. This study meta-analyzed 61 articles. It showed that open conversion rate was significantly higher in Roux-En group than in sleep gastrectomy group. In the 2 RCTs, the types of late complication requiring intervention were quite different in the 2 groups, but there was no difference in complication rates. This study was comparative meta-analysis of complication and reoperation between Roux-En and sleep gastrectomy. Pooled analysis showed that Roux-En had more overall complication after surgery. 2 RCTs show that there is no mortality at 5-year follow-up period. This meta-analysis showed that Roux-En gastric bypass has a similar all-cause mortality short-term compared to other restrictive surgeries, such as adjustable gastric banding or sleeve gastrectomy. This meta-analysis reported that bleeding and stenosis occurred more in early period after Roux-En gastric bypass than sleeve gastrectomy, but reoperation rate and mortality rate was similar between the 2 groups. And there was no significant difference of reoperation rate in 2 RCTs. But in this meta-analysis, the patients who received Roux-En may experience a higher rate of reoperation. How is the accessibility of Roux-En? Let's check popularity and learning curve of Roux-En. How is the popularity of Roux-En gastric bypass in US? The number of sleeve gastrectomy began to outperform Roux-En in 2013 and has increased dramatically over 5 years by more than 350%. However, Roux-En showed a decrease of more than 50% during the same period. The majority of operations reported in the IPSO registry are sleeve gastrectomies, followed by Roux-En gastric bypass. This graph shows the data for the IPSO regional chapters. Presenting sleeve gastrectomy is the most popular all of the world except Latin American chapter. This study was systematic review that compared between Roux-En and sleeve. It showed that it takes more time to master Roux-En than sleeve. This slide is a summary of previously mentioned studies. Given the results of the past 5 years, Roux-En is still standard in terms of effectiveness, but not safety and accessibility. Then, why do we still perform Roux-En gastric bypass surgery? We can apply this surgery to patients with uncontrolled DM, super obese patients, and GERD patients. This study was first study to construct and validate a scoring system named IMS score for selection of bariatric surgery according to the severity of diabetes, and suggests that Roux-En is recommended for patients with mild and moderate severity of IMS score. But the other studies show that Roux-En is superior than sleeve in mild and severe IMS score. Another famous scoring system is ABCD score. In these two studies, it was suggested that Roux-En is recommended for severe diabetic patients with low ABCD score. This study showed that Roux-En gastric bypass had a long, durable effect in non-obese patients with uncontrolled DM, although it had a small sample size and single arm. However, this meta-analysis of ICTs comparing Roux-En versus sleeve for type 2 DM in non-severely obese patients with at least 2-year follow-up didn't show that Roux-En had better diabetes remission rate and percent excess weight loss. This study is meta-analysis of 12 comparison studies between Roux-En and sleeve gastrectomy for super obese and super obese patients at 2-year follow. There is no significant difference in overall 30-day complications and mortality. Percent of excess weight loss showed a significant increase for super obese patients in Roux-En, but no significant increase for super obese patients. And diabetes remission was also significantly increased after Roux-En compared with sleeve. This study was a meta-analysis of GERD after sleeve gastrectomy. It shows the change in reflux increased by 19%. de novo reflux found 23%, esophagitis 30%, and Barrett's esophagus 6% in all studies. Large-scale study comparing sleeve gastrectomy to Roux-En showed only 16% of GERD resolved after sleeve gastrectomy, compared with 63% after Roux-En. This study was to report the impact of Roux-En on patients with Barrett's esophagus and show that Barrett's esophagus was decreased by 36% after Roux-En. In summary, Roux-En gastric bypass is still the standard procedure in terms of durable effectiveness and acceptable safety. For uncontrolled diabetes patients, super obese patients, or severe GERD patients, Roux-En is the most suitable procedure. Thank you for kind attention.
Good morning, ladies and gentlemen. I'm Kim from Korea. Today, I will present about the title, Should We Abandon Gastric Bands? Based on our 10-year experience about explantation of adjustable gastric bands. We have nothing to disclose. Like other Asian countries, in Korea, obesity also has reached epidemic proportions. According to the national surveillance in 2060, the prevalence of obesity in both male and female much more increased recently. Studies on the effect of non-surgical treatment options for obesity rarely extend beyond 12 months. Bariatric surgical procedures are known to achieve substantial weight loss and provide major secondary health benefits, especially in the long term. Due to its technically ease and safety and adjustability, and gastric band has been one of the most popular bariatric procedures. And unlike gastric bypass sleeve gastrectomy, it does not alter GI tract anatomy. However, in the long term, slippage, infection, and migration are the major causes of band removal. And additionally, we have witnessed disturbance of food passage and proximal dilatation of the bands, so namely superior pouch in patients, even they have not clear complications such as slippage or infection. The higher than expected rates of complications and the operation have resulted in a loss of favor of gastric bands. In this graph, American College of Surgeons NSQIP 2014 data, the gastric bands dramatically decreased between 2010 and 2014, and at the same time, sleeve gastrectomy is increased dramatically. Results regarding the long-term incidence of gastric band explantations are contradictory. The most published series have reported that about half of gastric bands are explanted in the long term, for example, longer than 10 years. However, Aurora reported that only 5% of bands were explanted 10 years follow-up, and their number of patients were very large, more than 700. And they concluded that from their data that the need for revision decreased as the technique evolved. So they emphasized the running curve effect. In the current presentation, we investigate the incidence, types, and causes of gastric band explantation over 10 years of clinical practice. In addition, we evaluate morbidities associated with explantation by different gastric band complications. This is a retrospective review of prospectively maintained data of the patient that underwent gastric band explantation as by single surgeon at a single tertiary center. The guideline of ASEAN Consensus Meeting on Metabolic Surgery regarding BMI criteria for AGB implantation were followed. We adopted past plaster technique and various band makers were used, such as wrap band, a Swedish band, the mid band. Band were left empty for 4 to 6 weeks after operation, when it was incrementally inflated over 3 or 4 sessions under radioscopic control in a radiologic chute. Subsequently, depending on the body weight changes, portion size, and hunger, small volume adjustments were performed without barium swallow. Barium swallow test or gastroscopy was performed whenever there was clinical suspicion of complication, such as slippage or erosion. The definition of gastric band complications are follows. Slippage SL group consists of patients diagnosed to have acute and chronic slippage with abnormal pi angle by upper GI barium swallow study, not corrected by completely deflating the bands. Dumb band erosion BE. The BE group consists of patients with moderate to severe symptoms attributable to intragastric band migration by endoscopy or infection of the band system by abdominal CT. Intolerance IT. The IT group consists of patients exhibiting functional or psychological intolerance. Functional intolerance was defined as partial or total food intolerance. Usually, a patient having band intolerance has moderate to severe esophagitis by endoscopy or pouch esophageal dilatation by upper GI without definite evidence of slippage or erosion. And contrary, psychological intolerance, the 3 characteristics were observed. The first is the proper band adjustment was not possible because the patient was concerned they could not tolerate band tightening. And the secondary, these patients often request gastric band explantation for fear of future complication. The last 3, but had no sign or symptom of esophagitis, and radiologic studies revealed normal pouch esophageal morphology without evidence of slippage or band erosion. Patients that underwent band-to-band revisional surgery, that is, removal and immediate replacement, were not included in the present study because we consider the latter patients maintaining their weight loss with their inside band or different from the patients having AGB explantation. This is the flow chart showing the management of adjustable gastric band patient. Between January 2009 and October 2018, a total of 267 patients underwent primary AGB implantation at Gachon University Gill Medical Center. And of these patients, 99 patients equals to 37.1% of the patients underwent AGB explantation. 4 patients were lost follow-up and their status were unknown at the time of this presentation. And there were 164 patients had their band in situ. Among those patients, band-to-band revision was performed in 9 of the patients, and among the 9 patients, 3 cases of AGB change due to systemic leaks and 6 cases of AGB explantation and immediate replacement due to acute and chronic band slippage. We also excluded in the analysis of the patients who underwent revisional sleeve gastrectomy with the concurrent AGB removal because they are beyond the scope of our presentation. So in the number of patients in the gray rectangle indicated the patients who were dealt with this presentation. Among the 99 patients who underwent AGB explantation, there were 13 SL patients and 39 BE patients, and there were 47 IT patients. And after excluding the patient who underwent revisional surgery, the isolated AGB explantation was performed in 82 patients. The SLI means isolated slippage. The BEI means isolated band erosion. ITI means isolated band intolerance. This is annual incidence and trends of adjustable gastric bands implantation or explantation over the study period. As you can see, the numbers of primary AGB implantation peaked in 2012 and then began to decline. Number of patients that underwent AGB explantation or conversion increased annually over the 10-year study period, and in 2015, the number of AGB explantation procedures started to exceed the number of implantation. This is the graph about demographic and anthropometric data of the patient at the time of band explantation. In this graph, as you can see, age and gender were not significantly different between SL, BE, and IT group. However, in IT group, namely band intolerance group, the BMI loss and total weight loss after primary AGB implantation was much smaller compared to SLBE group, and this is statistically significant. And their pre-removal health status defined by ASA criteria were not significantly different among groups. And in IT group, the follow-up period from band implantation to explantation was longer than SL and BE group, although significantly not different. This is a graph about annual case number of AGB explantation according to the etiology. SL means the patient underwent band explantation due to slippage. PE means band explantation due to band erosion. IT means patients who underwent band explantation surgery due to band intolerance. As you can see, there is high incidence of band erosion patients in the early period, and as time goes by, the patient who underwent band explantation due to band intolerance increased. This is a table of period data of patients that underwent isolated AGB explantation. Patients with BE group showed significantly longer operation time and longer hospital stay. In terms of band removal method, 23.1% patients underwent transgastric approach, that is, a short gastrectomy and division and removal of gastric band and closure of gastrectomy. There was significantly higher incidence of complication in BE groups. In about half of patients of BE group, antipyretics were used for post-op spiking fever. There was one patient having 3A grade complication who underwent PCD insertion for intra-abdominal abscess after removal of eroded gastric band. And there were 3 patients having 3B grade complication who underwent laparotomy or laparoscopy for intra-abdominal abscess. And finally, there were 2 patients having 4 grade complication 1 septic shock, and 1 hemorrhage shock. And technique total. In terms of Clavi and Dindo classification, there was significantly increased incidence of complication with minor or major complication in band erosion groups. AGB has been advertised as being designed for long-term use and to be reversed or removed if desired. However, during our initial 10 years experience, we found that 37.1% of bands has to be removed for slippage, erosion, or final intolerance. Furthermore, none of our 47 patients of band intolerance desired explantation, but band removal was necessary due to incapacitating symptoms irrespective of their desire. Is gastric band a safe surgical option? We found explantation of an eroded gastric band we associate with longer post-hospital stay, high serious morbidity rate, and high percentage of intensive care unit admission. And these are in line with other studies. Overall, the better outcomes achieved by sleeve gastrectomy in terms of weight loss and mobility have contributed to its popularity and accelerated the decline in AGB surgery over recent years. Today, sleeve gastrectomy is the dominating procedure in our country, followed by gastric bypass surgery. So our conclusion is, during 10 years of clinical practice, about 1/3 of our patients underwent NGB explantation. The most common indication for band explantation in the long term was band intolerance, and this was followed by band erosion and slippage. Intra-abdominal abscess and intragastric bleeding were rare but serious complications after removal of eroded gastric bands. Should we abandon gastric bands? I think the answer is yes or no. It depends on surgeons' familiarity of techniques and apt care of gastric bands. Although the results of our study do not discourage AGB use, potential candidates should be informed of the long-term high risk of the need for band explantation and its associated serious morbidities. Thank you.
Hi, I'm Aurora Pryor from Stony Brook, New York, and I appreciate the opportunity to share this talk with you virtually. I really wish I could be there today with you in person, but hopefully in the near future we'll be able to see each other again and get to have some great experiences together. My talk today is on redo bariatric surgery, when and how. My disclosures for this talk are from a variety of different companies for which I speak, although none are very relevant for this talk. So let's talk a little bit about bariatric surgery. The incidence of bariatric surgery has been climbing over the last few decades. And really since the year 2000, we've had a significant uptick in the number of cases that are done each year. When you think about the number of cases, it's pretty high, but there's also been an uptick in the number of revisional cases. And this is now quite significant. In fact, the number of cases we're doing for revisional bariatric surgery is about the same as aortic valve replacement cases. So this is really something significant and relevant for surgical practice today. So what do we revise for? Specifically complications or patients who need additional weight loss. Now, the kind of complications that we may see are reflux after sleeve gastrectomy, marginal ulcer, gastrogastric fistula, hiatal hernia, and a variety of other things. But these top four are some of the major things that I actually do surgery for in my practice. Reflux after sleeve gastrectomy is most straightforwardly managed with conversion to gastric bypass. And I find that that's because the bypass is a low pressure system. It actually manages reflux very well, and most of our patients are very happy with that. In addition, they're often additionally happy because they get additional weight loss with that procedure. Marginal ulcer is a little trickier. This happens in about 6% of patients after gastric bypass. Most of those can be managed medically, but sometimes if it is persistent or recurrent, you might need to do surgery. The two choices for that are a redo bypass, excising the ulcer and making the pouch smaller, or particularly for severe cases or recurrence after that revision, conversion to esophagojejunostomy is curative. The other relatively common complication, which may not need surgery, is a gastric fistula. In cases where this is combined with marginal ulcer, I think surgery is necessary, or it's a good reason for insurance coverage for weight regain. And then those patients, I would do a redo bypass. Hiatal hernia may or may not be combined with a revisional surgery, but that in general is required to have hiatal hernia repair if it's symptomatic. As I mentioned with marginal ulcer, this is a little bit tricky, but the procedure that I would recommend for ulcer alone or ulcer with gastric fistula does include a vagotomy and then resection of the area of the ulcer, and with the fistula, resection actually of the fundus of the stomach, which takes out the area with the fistula. And both of those have reasonable results and are relatively straightforward to perform. What I'm going to spend most of our talk talking on today is actually revision for inadequate weight loss or weight loss failure. And this is a little bit trickier. Even starts with a tricky definition where failure could be a BMI greater than 35 or greater than 40 for super obese patients, could be considered just less than 50% excess weight loss. Maybe it's persistent comorbidities, or could even be for patients who have weight regain after initial loss. So how would you consider these different diagnoses? So if you look at BMI greater than 35, that would have an average patient has 60 to 70% excess weight loss at 1 year. And most patients with a low initial BMI will stay under a BMI of 35. But for patients who start out with a high BMI, they may never actually get there. So that's not really a reasonable target for those patients. And they may actually have excellent weight loss and still have a high BMI. So less than 50% excess weight loss. So if you think about it, long-term excess weight loss after lap band is 47%. So on average, those patients are not going to have that as their target. Gastric bypass patients, they have a 27% total body weight loss at 15 years. That's pretty good. Although it's about 65% excess weight loss if you're 100 pounds overweight. And for heavier patients, that's not going to get there either. So you have to really think about what your goals are for any particular patient, and it may actually be meeting expectations, and others could consider it a failure. Persistent comorbidity, I think, is actually a pretty reasonable target if you're trying to do this to manage diabetes, hypertension, fatty liver disease, and those things don't improve. Maybe a redo operation will help get you there further. And I've definitely revised somebody who initially had diabetes and I performed a sleeve and then converted them to a duodenal switch with final curative results for their diabetes. So these can be a segmented and staged way to get there, although ideally you'll do this in a one procedure for most patients. Now let's talk about weight regain. This is a very well-cited study that's been around for a long time in bariatrics, and this is a Swedish obesity study looking at weight loss with surgery, but then subsequent regain over time. And you can see with any of the procedures that they studied in this series that all patients had some weight regain over time. So it's actually pretty common in our patients. And if you look for weight regain at all, most patients will have a little bit. If you look for weight regain to a threshold, I think that's more reasonable for considering revisional surgery. So again, all those different options, what do you pick? I think you pick what your insurance allows you and what's the right thing for your patient. But also you have to look at the reasons for failure. So why did this patient have trouble? Is there an anatomic reason? And I think that's really a critical thing. And that's actually the most straightforward thing, because if there's something anatomically wrong, I think you have a clear indication for a revisional surgery. So some of the anatomic things, we talked a little bit about gastric fistula. With lap band, which you don't see very much, but we actually still see the lap bands in follow-up. You can have a slip band. You could have a big pouch that's likely dilated over time. And there's some controversy about the concept of big anastomosis, but an enlarged anastomosis can be a reason that is responsive to revisional surgery. So let's talk about band to sleeve as one of the more commonly performed revisional procedures. So there was a sleeve gastrectomy conference, and this has actually happened on several different years, but those are surgeons who perform sleeve on a regular basis. And of the people there, 71% actually of those sleeve surgeons favored gastric bypass over sleeve as the revisional procedure of choice for failed lap band. But most of the surgeons did agree that sleeve is an acceptable option. And they talked that one-step or two-step revision could be considered options as well. And this led to some controversy. What do you do? What do you tell a patient? Is one-step or two-step the right choice? So the other thing to consider when you look at this is adding malabsorption. So do you convert the band or even a sleeve to gastric bypass or duodenal switch? So this is looking a study from Topard and al. From 2009, actually comparing revisional gastric bypass following band to primary gastric bypass. And they showed that their weight loss could actually be pretty equivalent to a primary procedure after banding. So I think it is a very, very reasonable thing to do gastric bypass after band. This is a study looking at the safety of single stage band to gastric bypass conversion. And this was all done from one institution. They looked at 94 patients undergoing band to bypass in one stage, and they matched them with primary gastric bypass patients. They showed no difference in major complications or length of stay. Minor complications were also similar. OR time, not surprisingly, was longer, and they showed a little bit less weight loss with that procedure, but again, felt that it was safe and actually good outcomes. Single stage band to sleeve, there was one study here from NSQIP, which is a nationwide program in the US through the American College of Surgeons. They look at sleeve to single stage, sleeve versus single stage band to sleeve conversion. Conversion patients were older with fewer comorbidities, but no differences in serious complications. So they also agreed that this was a very safe procedure, but slightly more complications than a primary sleeve. Our group actually looked at single stage band to bypass or sleeve out of a database that is from the quality improvement program that we participate in, the MBS AQUIP. Single stage conversion to sleeve, which was most common, or gastric bypass, and looking at reoperation, readmission, reintervention, and overall morbidity, we found that both procedures were very safe, but sleeve probably had a better safety profile. We also have data here from a study out of NYU looking at 1 or 2 stage band to sleeve gastrectomy, all from the NYU patient population, looking at OR time, length of stay, complications, readmission, reoperation, leak, abscess, and bleeding. And they felt in this study that complications were relatively similar, but some of the more serious complications such as leak or bleeding were higher in the 1 stage patient population. We did a study here out of the New York Sparks database looking at 4,000 patients of multiple New York hospitals, looking at 1 or 2 stage band to either sleeve gastrectomy or gastric bypass. And looking at the data here, you can see that those single stage operations, if you look at the total complications over 2 procedures, were actually much safer for both gastric bypass and sleeve gastrectomy. And again, the sleeve patients had slightly fewer complications than the gastric bypass patients across all of those different areas. So I do think single stage conversion can avoid another operation. A 1 stage procedure may be slightly more complicated, Particularly if the stomach looks bad or you have an eroded band, that would be a reason to delay that second operation. Follow-up surgery is not always easy, which is the reason I prefer the one stage if possible, and conversion is higher risk than primary surgery. So talking about sleeve conversion now, which is becoming a more and more popular procedure in our practice. Why does a sleeve fail? It's possibly too big. I think it may stretch over time, may have inadequate restriction for any particular patient. There's definitely no malabsorption with this procedure, although oftentimes that restriction balances with some behavioral issues, and that combination leads to lack of success for a patient. So the revision choices after sleeve are to re-sleeve, to do a gastric bypass. You can convert that sleeve to a duodenal switch, which is actually the historical second stage for a sleeve. There's now a single anastomosis duodenal ileostomy, or the Sadie procedure, which is based on the DS, but with one less anastomosis. Or you can try to train the patient and see if they can do some behavioral reset if they've really fallen off the bandwagon of appropriate behavioral modification. For a bypass, why does a bypass fail? The pouch can also stretch just like you get in the sleeve. They may have inadequate malabsorption. Maybe your anastomosis is too big, or it can be behavioral failure. And again, similar things that you would do with the sleeve patient. I do think it's good to start with your dietitian and psychologist and try to work with the patient to get them compliant with their diet and exercise strategy. But if they're doing that well and they're still having issues with their weight, then I think you can consider revisional surgery. So the revision choices for a bypass, and there have been a lot of things tried. As with any procedure, when you see lots of different options, it means nothing's really fabulous. So none of these are particularly great. Gastric band on top of a gastric bypass was done for a while with somewhat mixed results and somewhat more complications from those bands. So this has fallen out of favor in routine practice. Pouch revision can be done. Surgical pouch revision, if you're not having complications, is really not associated with great additional weight loss. But the endoscopic option can be done and is kind of a low risk potential gain procedure. So I think it's still something reasonable to try. Anastigmatic revision, again, surgical I think is not really that commonplace anymore, but endoscopically is something reasonable to try. Converting bypass to sleeve has been done. I would not recommend that, and particularly if you're looking for additional weight loss. What I do think does make sense is distalizing the gastric bypass, and I'll talk on the next slide a little bit about how that's done, and that is my choice for a compliant patient who's just struggling with their weight. There are groups now reporting on conversion of the gastric bypass to duodenal switch. It's a multi-anastomosis procedure, but can be done, and there are some reasonable results that have been reported. And definitely starting with the behavioral reset and making sure they continue through with that is an essential part of any of these interventions. So for the distalization of the gastric bypass, you have to think a little bit logically of what you're trying to come up with in your end result. And that's the roux limb should be 100 to 150 centimeters. In general, if they have any reflux type symptoms, I would focus more on that 150 centimeter for the roux limb. And then the goal is to get your total alimentary length of 400 to 450 centimeters. So to do that, I come up with a 300 centimeter common channel. So essentially, it's not just moving your roux limb, but you have to look at your biliopancreatic limb, your roux limb, and your common channel length to try to get this final configuration appropriate, and really make sure your total alimentary limb length is going to be at least 400 centimeters, or there can be some serious malabsorption issues with this procedure. But with that, we have had some good results in our practice, and this is something I still do today for people struggling after bypass. The other things to look for with bypass are there anastomotic issues, or are there some other reasons for anatomic failure? And again, all the testing you would do would be an upper GI series, endoscopy, and a full dietary evaluation. In addition, I do think it's worthwhile working with the psychologist and looking at intervention as needed, looking at exercise logs and plans, and make sure that it's not just your patient not following through, which is really commonplace, but looking for something that we can do more with the procedure. So before revision with good anatomy, following up on that, you want to assure your patient's been medically optimized. You want to make sure they're compliant with the behavioral program. And the only exception to that is if you're converting from a band, since I showed that data that you really can have outcomes pretty similar to primary bypass. So I think for those patients, you can be a little more lenient on lifestyle compliance. So let's talk a little bit about what procedures I would recommend with good anatomy and a compliant patient. So if you have a band, that's the most straightforward, but if you're really looking for good weight loss, I think bypass versus sleeve is a better choice to go, and that's what I recommend most of the time, unless my patient's unwilling to undergo gastric bypass. Conversion from sleeve, I do think sticking to the classic duodenal switch or Sadie procedure is appropriate unless they are having the complication of reflux, in which case you would do the conversion of that sleeve to bypass to manage the reflux and then hope for some additional weight loss, but it will not be as high as if you convert to a DS. For gastric bypass patients, there are not as many great options, and there are a lot of things that have been tried, but conversion to a distal bypass is what is the mainstay in our practice today. Duodenal switch is definitely the highest weight loss of any procedure, and I'm not sure what much more there is to do to try to get additional weight loss. Anything more distal can lead to malabsorption issues, so most of those patients are going to be actually better treated by adding medical management, and some of the new pharmacologic therapies may be a good option for them in your practice. Well, thank you so much for your attention today, and thank you for the opportunity to present from the US at the K-Cells meeting. I really wish I could be with you and hope to be in the near future. Thanks again.
이조 선생이 음소거 되어 있습니다.
Okay, everyone, thank you for your nice presentation. 안 들려요?
아, 들립니다. 네네. 네, 이제 들립니다. 네.
됐어요? Okay. Okay, thank you, everyone. Professor Park, are you here? Oh. No questions from the audience? Professor?
Yes,
Uh,
yes, here.
and Professor Sungmin Kim, are here?
Sungmin Kim not here.
Uh-huh.
Can I have a question to Dr. Pryor?
Okay, thank you.
Yeah, yeah. Actually, your presentation is very good, but unfortunately, the mechanical electronic system is not working so well. So I'm very unhappy to hear all your presentations. So my question is, your slide shows that after marginal ulcer, after Roux-En gastric bypass, and then you did the bypass, redo bypass surgery or esophagojejunostomy, right?
Correct.
So in my opinion, is it working for weight loss to esophagojejunostomy?
Yeah, so it's an excellent question. You would worry that you take away the gastric pouch and they're no longer going to feel the satiety that they get with a gastric bypass and then regain weight. But I have not actually seen that in our practice. So surprisingly, if you revise for an ulcer and take out the pouch and do the esophagojejunostomy, I find that our patients usually maintain their weight loss.
Okay, thank you.
I'm very sorry. Can you hear me?
Yes.
Yes.
I'm very sorry. Maybe I was double logged in, so I got I have lost my line. I'm very sorry. So thank you for the speakers, and I'm sorry that we don't have Dr. Sungmin Kim who talked about the band erosion or something. So the first question to Kyung-Won sir, maybe this question from United States. So did you think about the resectional bypass to reduce the risk of gastric cancer? So yeah, most Western doctors are curious about the resectional bypass when we need to do Roux-En for our Asian patients who has a very high risk after surgery interview. How do you think about that?
Yes, thank you for a good question. And actually, I did 3 cases of laparoscopic resectional Roux-En gastric bypass. It is the Roux-En gastric bypass combined remnant gastrectomy. It is also covered by Korean National Health Insurance System, and I have a policy to choose resectional Roux-En gastric bypass. The first is the old age over 50-year-old and chronic gastric metaplasia and or precancerous reason metaplasia and H. pylori infection CLO test positive. And I think that roughly speaking, the causes of gastric cancer is 3 main causes. First is H. pylori infection, and second is food, so-called carcinogen, and the third is family history. It means the patient have a gene for gastric cancer. So I tested endoscopy preoperatively to operate bypass surgery, and we checked the CLO test. If the patient CLO negative, it is okay. And I asked the patient, do you have a gastric cancer patient in your close relatives? If the patient don't have gastric cancer patients in the relatives, so I do the non-resection, the standard Roux-En gastric bypass. But in the older patient do want bypass surgery to cure the diabetes more and more, and I do the laparoscopic resection Roux-En gastric bypass. Is my opinion.
Professor, so I can agree with your opinion for the indication of a resectional Roux-En bypass. But the problem is how difficult is that? So, Dr. Pryor, have you ever experienced resectional Roux-En bypass on bariatric patients, or Asian patient or someone?
Well, so I've done it for chronic ulcers or other gastric pathology, but it's definitely not as common here as I would expect it to be in your cohort of patients in Korea. But we've had minimal complications from the resection because it's not an existing cancer. You don't have to do a big dissection. It actually can be a perigastric dissection. So I think it's a little bit easier and technically less complicated.
So, sir, how
Yes.
is it difficult doing that? Doing
Resection
resectional
bypass.
Roux-En bypass. Is it more difficult than standard Roux-En, or is it easy for us to do that?
No, not difficult. We are Korean surgeons are the almost the Korean surgeons are gastric cancer surgeon. We do the laparoscopic total gastrectomy daily, and we do the resection very easily. But we cautious the postoperative oozing or bleeding after surgery because the high BMI patients have a bleeding tendency because of we prescribe the low molecular weight heparin prior to prevent deep vein thrombosis. So we do a very cautious hemostasis during surgery.
All right. So I have a question to Dr. Sang-Hyun Kim. So you spoke about the learning curve between Roux-En gastric bypass and sleep. So in terms of learning curve between them, I was surprised to see that a longer learning curve in Roux-En gastric bypass. I think that for Korean surgeons who are very skillful in the gastric resection or something, because of a high incidence of gastric cancer patients here. So, do you think is it a real situation for Korean surgeon to have more learning curve performing Roux-En gastric bypass than sleep?
Actually, in my experience, and at first, when I started to bariatric surgery, the sleeve gastrectomy is easier than the Roux-En gastric bypass, and then I have more experience, and then the sleeve gastrectomy is getting more difficult than the Roux-En gastric bypass because in my slides, the learning curve is based on the operated time and complication rate, only two parameters used. So I think the most important thing is the weight loss and long duration. So definitely the weight loss of long duration is have to be included in the learning curve. So I think the Korean surgeon, as you mentioned that previously, the Roux-En gastric bypass is a little bit easier in Korean surgeon, I think, but I don't know the exact learning curve, the case of the number of cases.
The number of cases of sleeve is shorter than Roux-En, or which one is a longer and complicated procedure, even to the Korean surgeons? What do you think?
Actually, according to the operative time and complication rate, and sleeve gastrectomy is easier than Roux-En gastric bypass in Korean surgeon, but including the weight loss about after surgery, so sleeve gastrectomy seems not so easy than the Roux-En gastric bypass, in my opinion.
Okay, Dr. Pryor. He's talking about outcome-based learning curve, for especially for sleeve gastrectomy. I mean, the volatility of the outcome of sleeve gastrectomy is very high, I think. So, how do you think about it? The result variation by institution or by surgeon? So how it means it is about the easy but not simple operation for the sleeve gastrectomy. How do you think about it?
Yeah, so I think sleeve is pretty straightforward, but there are a lot of nuances to the procedure, how you twist your staples to keep your staple line straight. And there's a couple areas that if you get too tight, it can definitely cause a problem with stricture or obstruction, and that can actually lead to leak. So we've actually shifted in our practice. So from doing a tight sleeve, which Dr. Kim nicely presented, we actually use a 36 to 38 French bougie to make it a little bit wider to try to minimize the complications. And we found that the outcomes still track very nicely. So I think if you go a little bit larger, you've got more tolerance and it makes the procedure more straightforward. So it's easier for people to learn and adopt that in their practice. I think bypass, if you can sew an anastomosis well, which you guys do a lot with all your gastric cancer, that sets you up well to make a bypass learning curve more straightforward.
All right. So I have some questions for you. So the first one is, what is your choice in patient with severe reflux with hiatal hernia after sleeve gastrectomy? Conversion to bypass or hiatal hernia repair?
So hiatal hernia repair with conversion to bypass, both.
Yes.
But
both.
not leaving the sleeve.
Mm-hmm.
And when you do that, I think it's important to keep your roux limb long enough because you do find some motility issues in the bypass patients. So I'll make a 150 centimeter roux limb to make sure that that's not going to be a problem post-operatively as well.
All right. So because in Korea here, you know, our most majority of bariatric surgery is sleeve. So I will ask about the revision for sleeve. So you talked about when there is a persistent comorbidity in case of diabetes, when after the sleeve, so you would choose Jordan switch or SADI. Why not Roux-En gastric bypass?
So we've looked at converting sleeve to gastric bypass, and the additional weight loss is about half of what you get when you convert sleeve to duodenal switch. So if you're really doing it to treat extra weight or extra comorbidity, duodenal switch is going to get you a lot more. But you have to make sure that those patients are going to be reliable. They're going to come to your clinic. They're going to take their vitamin supplementation, get screened, because that does add a whole level of malabsorption. And you want to make sure that your patients, if they're going to be malabsorptive, are going to follow up well.
So you would prefer skip Roux-En gastric bypass? The first operation was sleeve.
Well, yeah, I don't want to, I mean, people do it, but I think converting a gastric bypass to a duodenal switch is a hard operation. And particularly in Korea, if I were converting a sleeve to gastric bypass, I would take out that distal stomach.
All right.
So you couldn't convert that patient down the road to a duodenal switch.
Okay.
Sorry. SADI is very popular in your practice, in your institute?
So we're funny. Our insurance makes it hard to get SADI approved. From a science standpoint, I think it makes a lot of sense. If I got to pick on my own without having to get the procedures covered by insurance, I would do a SADI as my conversion procedure routinely. But because of insurance, I actually do a Roux-En duodenal switch, which is the standard operation.
Okay.
Right. The second case, I wanna get some comments from you. In case of revision for sleep gastrectomy, so you do Roux-En gastric bypass. Is there something specific procedure regarding anastomosis size or at the gastric gastroctomy or the limb length?
So the limb length, I do think that 150 centimeter roux limb is important for reflux patients, and I do that routinely. If you get a shorter roux limb, you may have some reflux back with the normal post-operative Roux-En-Y dysmotility. So I think you really want to make sure that you get that 150 centimeters, even with low BMI. People can do just fine. Weight loss isn't really different in the studies that have compared the two. So I think that's safer. In terms of the anastomosis, there's two camps. Some believe that the anastomosis size is super critical. Other people don't really believe. If you look at people a year or two out after bypass, most of the time that anastomosis is going to stretch and be about the size of the bowel. So I'm in the believer group that the anastomosis size is not that critical. I'll make a 2 to 2.5 centimeter stapled anastomosis and then hand sew the defect, and that does really well in my practice.
So you don't have any specific procedure when you do primary Roux-En gastric bypass or you do revision for sleep gastrectomy? Same way.
Yeah, so the pouch and the roux limb are the same, and the biliopancreatic limb about the same. So that ends up being the same procedure, except there's no big remnant.
Yeah, regarding your comment about the anticoagulation, can you speak about that in detail for everyone?
Yeah, so this is kind of an interesting question, and how it came up is that in our practice, we have this nationwide database now that we can compare outcomes. And the one thing that we were a little bit of an outlier on in my practice is we had a slightly higher rate of bleeding. And when I was learning to do robotic surgery, I went to another practice, and they did not give any preoperative anticoagulation. And I thought that was crazy, and why would you do that? And she says, it's fine, we have no problem. So I decided I was going to study this. So it was a question. We had good surgeons on both sides arguing. So we used a database that was from the electronic medical record of multiple institutions across our country, and I could track bariatric patients. We could figure out when they got anesthesia, when they got their anticoagulation, be it Lovenox or heparin, and then when they actually got transfused, if they had any bleeding complications, and if they had a new diagnosis of a VTE event, either a DVT or a pulmonary embolism. And with that, we showed that if they got preoperative anticoagulation, they were more likely to bleed. But there was no difference between preoperative and postoperative anticoagulation in terms of a VTE event. Now, if you didn't get anticoagulation, you would have a clot. But that shifted our practice, so we just give postoperative, and we've had no increase in our VTE events, and our bleeding now is in the top decile. So it's really made a difference in our outcomes.
All right. Is there any question for each other or?
Yeah, Dr. Aurora. Oh, I'm sorry. Your first choice at gastric banding, your revisional first choice is gastric bypass, right?
Correct.
Yeah, but many surgeons perform gastric sleeve gastrectomy after gastric banding.
So it's safe to convert to sleeve, but if you look at the weight loss comparisons in the trials that have randomized to the two, that you're going to find that the weight loss is better with bypass. So if you're having failed weight loss as your indication for revision, that's why I think bypass makes sense. If you've done well with your band and it's slipped, or you've had an erosion, I think sleeve makes sense.
Okay, your choice is selectively can be the sleeve gastrectomy can be performed selectively for after sleeve gastric banding.
Yeah, we've actually, our group has looked at that. It's a very safe operation. It's probably a little bit safer than converting to gastric bypass. But if you're doing this to get added weight loss, you're going to have more weight loss with bypass.
Okay. Okay, we ran out our time. But the last question is very simple for Dr. Pryor. So it was very interesting to me that your department name is August and Advanced GI Surgery. What's that mean, advanced in your department?
Well, so it really is just the shift in how people are calling things in the US. So advanced GI is now a new specialty. So it's just that we do endoscopic therapies and minimally invasive therapies, and we're trying to, you know, do everything on the forefront of what's changing. So we're not just doing open old-fashioned surgery.
Okay, that's not because of your now doing robotic surgery for your bariatric patients.
We do that too. But I personally actually learn robotics, and I'm now back to doing things by hand. I'm more efficient.
Yeah, for robotic surgery, I experienced that the minimum bleeding when we do robotic surgery is very it gives me very difficult when we do laparoscopic surgery, because it shows us a very big view for us. So anyway, so congratulations on your very recent name of your advanced GI surgery. So
thank you.
Yeah. So thank you for the Professor Joo-Ho Lee co-chair with me, and then our both speakers except one. He cannot be here with us. Thank you so much for this discussion, and see you in the near future. Thank you so much.
Thanks for having us.
Thank you, everyone.
Thank you. Thank you. See you again.